And welcome everyone. Yeah, I should have said, yeah, thanks, Aaron. Start the recording. Welcome everyone. I'm Tony Latime, president of the Society for Functional Precision Medicine, and welcome to our monthly webinar series. We will shortly be hearing from Dr. Pishvaian from Johns Hopkins University. Just a couple business things before we get into that. I wanted to show you our website. We continue to sort of build on it, and it's very easily reached at sfpm.io. On our front page, we have various sort of eye-catching things, the most obvious things you might want to do as a member. You can find the next upcoming seminar series, and you can add the whole meeting series to your calendar, or you can learn about the person who's speaking. We're also very happy to publish recent news, and I'd encourage members to take advantage of this. If you have a paper, a finding, a clinical trial, whatever it is that you would like to get a little more action on, please let us know and we'll post it here. I'll also say at the SFPM on Twitter, if you're posting things on Twitter, and we will amplify as best as we can your signal. For those of you so inclined, there's also opportunities to support the SFPM, and we are very grateful to the sponsors that are listed here: Trevera, Presage, Excientia, Kiatech, Zillis, and 2Curex. Thank you very much for your support. We also appreciate the support of our members who re-up their membership. If you have not done this recently, then you probably are due for doing this. So please, what you do is go to your membership portal here, and then you log in. I've already logged in so that it took me past the login page, and then you can redo your membership when you're here. The other opportunities you have are to post a job. If you are looking for a job, you could check that. You could check out our jobs page. But if you want to post a job, you have to be a paid member. Also, if you want to look at the monthly seminar recordings, you can see I'm doing right here. You can access them, but only as part of our if you're a paid member. And all the previous talks where the presenter has agreed are presented here for you to review again. So I just want to encourage you to use our website and also communicate with us on social media when you have the opportunity to raise the visibility of SFPM and also raise the visibility of your own work. So with that, I also want to alert you that you're probably going to see some emails broadcasting a little bit about some election action that will be upcoming. The details will be in an email, but there will be some elections for a few of the board positions on the SFPM for you to be aware of. With that, I will unshare, and Diana, you can take it over from here and introduce our speaker. Thank you.
Yes, thank you. Good morning, everyone. My name is Diana Azam, and I am an SFPM board member. It's my delight to welcome and introduce Dr. Mike Pishvaian. But before that, I just want to echo what Tony mentioned. I encourage all of you to pay your membership dues. If you're already a member, please go ahead and check if you've paid your dues for next year, and also encourage everybody to become a member of SFPM. As you saw, you get a lot of benefits in becoming a member, and we want to work as a team to combine the efforts and raise our visibility. So if you have any questions, feel free to reach out to me or Tony or any other SFPM board members, and we will help you through the process. All right, so it's my pleasure again to introduce Dr. Michael Pishvaian. He's the Director of Gastrointestinal Developmental Therapeutics and Clinical Research Programs for the Johns Hopkins Kimmel Cancer Center, and he's also an Associate Professor at the School of Medicine. Dr. Pishvaian is a fellowship-trained gastrointestinal oncologist specializing in pancreatic and refractory colorectal cancers. Dr. Pishvaian came to Johns Hopkins from the University of Texas MD Anderson Cancer Center in Houston, where he spent a year as a co-director for clinical research at the Sheikh Ahmed bin Zayed Al Nahyan Center for Pancreatic Cancer Research. Prior to that, he spent 12 years at Georgetown University's Lombardi Comprehensive Cancer Center, where he directed the Phase 1 clinical research program, served as the medical director of the Clinical Research Management Office, and co-directed the Roche Center Pancreatic Cancer Program. Dr. Pishvaian received a bachelor's degree in biology from Duke University and completed medical school and a PhD program in tumor biology at Georgetown. He stayed on at Georgetown for an internship and residency in internal medicine and a fellowship in hematology oncology before he joined the faculty there in 2007. So his research is focused on providing precision medicine approaches to identify targeted therapies for patients with pancreatic and advanced colorectal cancers. So without further ado, welcome, Dr. Pishvaian, and thank you for agreeing to give us a seminar and being part of today's seminar.
Absolutely. And thank you for the invitation and really for this esteemed group that I'm part of. Just to clarify, just to put things in proper context, I'm looking over the GI and phase 1 programs down at our satellite hospital in DC, not for the overall Baltimore program, but obviously I am part of the Hopkins program writ large. And I'm going to talk to you today. Let me share my screen. I'm going to talk to you today about precision medicine for pancreatic cancer. Much of this will be a relatively clinical translational talk, because I think that pancreatic cancer has been incredibly frustrating, as many of you know, in trying to tackle what is it exactly that's causing pancreatic cancers to be so resistant to chemotherapy and make it so difficult to try and beat as a disease. But what we're learning is that there are small biomarker subgroups that I'm going to go through in great detail right now that might help at least some of the patients that we treat with pancreatic cancer. So with that, let me dive into the discussion. These are my disclosures. So today I'm going to talk to you about the frequency of actionable alterations in pancreatic cancer, which actually have increased over the last several years, the current data for using targeted therapy for selected patients with pancreatic cancer, and then talk about some of the more novel targeted therapies that may be relevant in the coming years. To set the stage, this is where we are with pancreatic cancer. I actually just updated this slide last week with the Cancer Facts and Figures 2023 data, and was of course disappointed to go from 62,000 to now over 64,000 pancreatic cancer patients a year, with a death rate that has now crossed 50,000 officially. So it's soon to be the second leading cause of cancer-related death in the United States, probably by 2030. And a lot of this is because pancreatic cancers are often identified at a later stage where 80% of them are inoperable and probably will never be rendered operable. And as a result, it's got the lowest survival rate of any major cancer at 12% 5-year overall survival currently, which is better than 4% 10 years ago or 20 years ago, but is still, we've got a long way to go. So I thought I'd start with a typical patient scenario just to sort of lay the groundwork. This is not uncommon for what we see in the clinic on a regular basis, a 58-year-old female. I chose female just to emphasize the fact that there's no gender predominance for pancreatic cancer. No family history of cancer. The patient presented with pelvic pain. Workup revealed incidentally identified metastatic pancreatic cancer with liver metastases. Germline testing was done and did not reveal any inherited mutations. And so unfortunately, while we can definitely help treat these patients, we know the overall story of how things will go for most of these patients based really on 2 regimens that now are 10 and 12 years old. FOLFIRINOX and gemcitabine nab-paclitaxel are our standard chemotherapy cocktails. FOLFIRINOX came out in 2011, was proven to be better than gemcitabine. Gem-nab-pac was also proven to be better than gemcitabine. These are still our 2 standard regimens. I'm happy that we have them because when I started on faculty in 2007 and all we had was gemcitabine and patients just sort of did very poorly, and at best you would slow their decline. Now with FOLFIRINOX and Gem-nab-pac, you actually can recover patients' functionality, improve their quality of life, sometimes even back to normal levels, and maintain a level of plateau. But ultimately, these are regimens, and this is a cancer that is ultimately terminal, and we are at best trying to slow the inevitable. We do also now have a second-line proven regimen of 5-FU and nanoliposomal irinotecan or Naliri. This is just to highlight that we do have a standard approved second-line regimen as well that has also further improved the overall survival. And in fact, actually, when you sequence these regimens, we know that from data in the 90s that patients who never got any treatment with their pancreatic cancer, their survival time was estimated to be quite short, 2 to 4 months. The current first-line standard of care survival is about 8 to 11 months, probably a little bit longer. And then the current second line is about 6 months. But really, when you have a patient that you're able to offer them the ability to sequence therapy, so they're getting all 5 of our active regimens between FOLFIRINOX and Gem/Nab-Pac, then their overall survival is probably more like 15 to 18 months. And that's a number that I see fairly often. But what I also see is that there are these outliers, these roughly 5 to 10% of patients whose survival times are measured in years and 30 months and probably in some cases even longer. And the million-dollar question is, who are these 5 to 10% of patients? How can we identify them proactively, prospectively? And importantly, can we expand this group to be more than just 5 to 10%? And of course, in order to be able to answer that question, we need to identify and understand the biology of each of these patients' cancers individually, and then, of course, treat them according to their disease-specific biology. And that really is the underlying promise of personalized or precision medicine, as you all know in this group very well. The idea that we can use predictive biomarkers to identify who will benefit from specific therapies. Just in terms of establishing a definition, when I talk about pancreatic cancer and precision medicine, what I'm really talking about is molecular testing for a therapeutic purpose, where we assume and hope that in any individual patient, there could be distinct targetable molecular abnormalities that are potent predictive markers of response. And these are what we call the quote unquote actionable biomarkers. The other thing is that the definition of actionability can vary significantly. So the definition that I like to use is where there's quote unquote significant activity. What does significant mean? Well, that's definitely in the eyes of the beholder. But for me, where I see that the results in any cancer type for a patient with that molecular abnormality leads to a disproportionate benefit compared to what you would normally see for that cancer type. And I'm going to go through a bunch of examples of what I mean. One quick digression is that precision medicine is not necessarily the same as molecular classification. Molecular classification is really about taking large data sets and doing molecular subtyping, usually from gene sequencing and transcriptomic data, such as the International Cancer Gene Consortium and TCGA. And the goal really is to define specific molecular subtypes, often that are pathway driven, and sometimes these can also reveal prognostic groups with even predictive relevance. In pancreatic cancer, we are starting to see that shape out or bear out, where molecular classification, and I'm kind of summarizing in here, that there's 2 core subgroups that have been identified, and Eric Collison did a nice job reviewing this a few years ago. And our 2 core subtypes are the squamous or basal-like subtypes, and then the classical pancreatic cancers. And when the molecular profiling reveals the distinct pathways, then of course it begs the question, well, are these pathways potentially targetable? So starting from way back to kind of the earlier Hopkins group, looking at just cell lines of pancreatic cancer, they were able to define 12 distinct subgroups. Those subgroups have actually broadened much more significantly, and the pathways are being further refined. And they are starting to be linked to distinct targetable subgroups, where in theory, some of these pathway aberrancies can also be connected with certain therapies that we see. And that's really where my sort of interest started to be developed over the 2000 teens, where we were looking for these actionable mutations. And this is the data from the Know Your Tumor program, but also this data really replicates probably 8 to 10 other major publications representing well over 5,000 individual pancreatic cancer patients over the last 10 years that have been sequenced. And we're seeing a consistent theme. And that theme is that more than 25% of pancreatic cancers have potentially actionable molecular biomarkers. And what you see here on the left is kind of a list of many of those biomarkers that could be relevant, some of them with proven or at least anecdotal clinical data in pancreatic cancer, others with data in other cancer subtypes. The majority of these mutations are in the DDR or DNA damage response and repair pathway, and we're going to go over that in more detail. But then there's a whole bunch of small subgroups that are uncommon. I don't like to use the term rare. The definition of rare is less than 1 in 2,000 patients, so it's not quite that uncommon. But these are uncommon subgroups that are potentially targetable or actionable with specific therapies. And the more of these small subgroups that we identify, the more we may be able to carve out specific subgroups of patients that benefit. So let's go through some specific examples. And of course, the one that's easiest to start out with, because it's a drug that's approved in a disease agnostic way, it's approved based on a molecular biomarker, which is microsatellite instability, is the use of pembrolizumab in MSI-high pancreatic cancers. This is from the original science paper from Young Lee, my colleague here at Hopkins, and Luis Diaz, who published this initially. And in the initial publication for pembrolizumab for MSI-high cancers, there were 6 pancreatic cancer patients. We now know that this is a pretty uncommon finding in pancreatic cancer, probably representing about 0.5% or 1 in 200 of all patients. But when these patients got treated with pembrolizumab, they did benefit. In fact, in the original 6 patients, all 6 of them had some clinical response. 4 of the 6 of them was a RECIST criteria response. The other disease agnostic approvals that have happened in the recent years have been with the TRK inhibitors, both larotrectinib and entrectinib. This is from the Memorial Sloan Kettering, Alex Drillin, sorry, it's my light switch, data, showing that many patients with NTRK fusions can benefit from TRK inhibitors. This is, again, across multiple disease types. The arrows in this case are not pancreatic cancer, it's any GI cancer. There was actually only 1 pancreatic cancer patient in this original publication who did actually benefit from a TRK inhibitor for NTRK fusion positive pancreatic cancer. We looked at a more defined subgroup of pancreatic cancer patients treated with entrectinib, 2 of whom had an NTRK fusion, another one actually had a ROS1 fusion. And in these cases, these 3 cases, these patients experienced prolonged and actually in some cases a very dramatic benefit in improving their quality of life and their clinical outcome. The example here of this patient who's in this PET scan that you see here, this patient was one of my colleagues' patients. The patient was literally on their way to hospice, was enrolled in hospice, and the NGS test results came back, and an NTRK fusion was identified, and the patient was able to get on study. And you can see that this is September 2016, this is October 2016. Within a month, they had almost complete resolution of all the PET or FDG avid lesions. Their symptoms improved dramatically, and the patient literally had almost like a Lazarus moment. So this is uncommon to very uncommon, but it does happen, and we need to go looking for it. If we try to identify a subgroup of pancreatic cancers that are more likely to have these alterations, although not always, these aren't completely overlapping, these aren't completely exclusive Venn diagrams, are the KRAS wild-type subgroup of patients. So we've known for decades that patients with pancreatic cancer, about 90 to 95% of them harbor KRAS mutations. It's believed to be one of the key mutations in both the development and the sustaining growth of pancreatic cancer tumors. But about 5 to 10% do not harbor KRAS mutations. And when a group of investigators went through the Foundation Medicine database, this is led by Artur Singh at University of Pittsburgh, they found that about 12% of tumors were KRAS wild type, and that out of 47 KRAS wild type tumors, there were fusion genes identified in multiple potentially actionable genes, including FGFR2, RAF, ALK, others, that could actually lead to specific patient outcomes. So some of the centers, including our own and including other centers, have said, okay, we're not going to test a broad panel, including a fusion gene panel for all pancreatic cancers, but we will certainly test it for the KRAS wild-type tumors because they're very likely to harbor these kinds of other actionable alterations. So one of those is in BRAF mutations, and BRAF mutated pancreatic cancer occurs about probably 1 to 2% of all pancreatic cancers, but these BRAF alterations are potentially actionable. In our Know Your Tumor database of over 700 patients, there were 18 patients with BRAF alterations, 5 of whom had the classic BRAF V600E mutations. And in this case, anecdotally, when these patients were able to get access to classical BRAF V600E targeted therapies such as dabrafenib and trametinib, they actually did benefit. And in fact, there was at least 2 or 3 sustained partial responses in BRAF V600E mutated patients. So much so that we've actually launched a phase 2 trial of encorafenib, binimetinib, for BRAF V600E mutated pancreatic cancers. We're having trouble accruing these patients. We're trying to get them referred to us. If you know of anybody who might be able to help find these patients, that would be great. What I can tell you is that of the small number of patients that we've accrued, we've already reached our threshold for going to the full trial. So we're already seeing success in these small groups of patients. Another more recent small subgroup, probably representing about 2 out of every 200 patients, so about 0.2%, are those who have NRG1 fusions. NRG1 fusions are pretty uncommon in cancer in general. When they occur, they're most likely to occur in non-small cell lung cancer and in pancreatic cancer. When these NRG1 or neuregulin-1 oncogenic fusions occur, they can respond to pan-HER inhibitors and also to HER2, HER3 inhibitors such as seribantumab and zenocutuzumab. And there are data now being generated with these drugs. For example, this was presented at ASCO last year, so about a year ago. On the left-hand side, zenocutuzumab, and on the right side, seribantumab, both HER2, HER3 bispecific antibodies that are relevant for NRG1 fusion positive cancers. And you can see that for the pancreatic cancers, the PDACs, there was a 42% response rate for NRG1 fusion positive cancers. For what it's worth, 35% also in non-small cell lung cancer. So we're hopeful that this is a subgroup of patients that's also going to have durable benefit. Another receptor tyrosine kinase that is clearly seen to be active in a small group of pancreatic cancers are those with RET fusions, and pralsetinib, and also, I can't pronounce this, selpercatinib, has been shown to be active in RET fusion positive cancers in general. In fact, selpercatinib is now approved for RET fusion positive disease, but pancreatic cancers can certainly be approved in these groups. We had the pleasure of having Dr. Subia from MD Anderson give a talk to us recently, and in his trial, this Blue 667 trial, the number of pancreatic cancer patients is now up to 6, and all of them responded to therapy. So again, if you go looking for it and can find these patients, they have a very good chance of benefiting. What about trying to target KRAS itself? Well, that's been the most elusive target over the last 30 years, but we're finally starting to make some headway, including in specific molecular subtypes of KRAS mutations. Lately, it's been the KRAS G12C targeted therapies, and as many of you probably know, this is a specific mutation that has an alteration that is more likely to be targetable by these drugs. So both adagrasib and sotorasib can target the KRAS G12C mutation effectively. And in the Crystal-1 study presented by Tony Saab last year, adagrasib had a 100% disease control rate and 50% actual frank RECIST criteria response rate for patients with pancreatic cancer that harbored KRAS G12C mutations, with a median duration of response of 7 months. This is better than any second or third line chemotherapy that we have available for us. These KRAS G12C mutations do not occur very often, unfortunately, in pancreatic cancer, probably about 1% or about the 1% range. And just to not ignore sotorasib so that we're not drug specific, this is also an active agent in KRAS G12C mutated pancreatic cancers. And again, this is published by John Strickler this year in New England Journal, where patients with KRAS G12C pancreatic cancer could actually have frank responses with this agent. This has also opened the door to being able to target other KRAS specific mutations, as well as potentially looking at KRAS combined therapy to try and increase the responsiveness. So one of the strategies that I know is being actively explored is looking to see if we can actually use a KRAS inhibitor in combination with an anti-EGFR inhibitor. Anti-EGFR inhibitors have not been successful in pancreatic cancers, but perhaps by rendering the tumors effectively KRAS wild type by combining it with a KRAS inhibitor, then this actually may really up the game. And in fact, in colorectal cancer, thanks to the work of Roni Yeager at Memorial Sloan Kettering, the combination of sotorasib and one of the anti-EGFR inhibitors, cetuximab, I believe, there was a 100% disease control rate and a very high response rate for KRAS G12C mutated colon cancer. So we're certainly hoping to be able to replicate the same for patients with pancreatic cancer. So I mentioned that the most common alteration seen in pancreatic cancers that are potentially targetable fall in the DNA damage response and repair pathways. And this is, as you all know, a highly organized pathway that will allow for a cell to detect DNA lesions that can occur, to slow the cell in the cell cycle, allow for hopefully the most effective repair, which is homologous recombination repair, or the more error-prone non-homologous end joining repair if HR is not available to the cell. And we see that in pancreatic cancer, about 17, in some cases up to 25% of pancreatic cancers harbor alterations in the DDR genes. I think we as a group have become better about defining the quote-unquote canonical homologous recombination DDR genes, such as BRCA1, BRCA2, PALB2, and we don't necessarily know what to do about some of the other non-canonical genetic alterations, such as ATM and others. But clearly there's activity when you target these mutational subtypes with specific therapies, the most simple one being platinum-based therapy. One of the arguments that I've heard said to me directly about why we shouldn't be doing testing for all pancreatic cancer patients is, oh, they all will get platinum-based therapy anyway. But the reality is that that's not true. As I mentioned from the beginning, gemcitabine nab-paclitaxel is a perfectly appropriate regimen that I use routinely for my patients with pancreatic cancer. And unfortunately, we know the data that about 50% of patients with metastatic pancreatic cancer who start on frontline therapy never make it to second-line therapy. So if we were to know that there were certain subgroups of patients that would benefit from platinum-based therapy, we should figure that out so that we can get them on the right therapy from the beginning. So we were able to ask that question more systematically in the Know Your Tumor database, where we actually had patients who were treated with platinum-based therapy at any point during their pancreatic cancer lifetime versus those who never received any platinum-based therapy, and then lay over their mutational subtypes. And what we found is that if you take a platinum-naive patient, a patient who never received platinum-based therapy for their pancreatic cancer, and then looked at those who were DDR altered versus DDR wild type, there was really no survival difference. If anything, the DDR mutation had a very slight decrease in survival, although this was not statistically significant. By contrast, if you look at the survival for patients who were DDR mutated and received platinum-based therapy, they lived almost a year longer than those who were DDR wild type. And in fact, when you compare across these two graphs, the patients who were DDR altered and received platinum-based therapy lived about a year and a half longer than those who were DDR altered but never received platinum-based therapy. So it's really critical to know who those patients are and to treat them appropriately. In fact, if I have a patient who's treated with gemcitabine nab-paclitaxel for purely clinical reasons, and I'm in the middle of and in the process of testing their tumor or their germline, I realize that they actually have a DDR alteration, I will be very conscious about making a decision. I don't want them to miss the opportunity to have platinum-based therapy at some point during their pancreatic cancer lifetime. And along those lines, in trying to think about who we need to test, is really the idea that we're also identifying patients who have germline mutations in these key DDR mutations, such as BRCA1 and BRCA2. So 5 to 7% of patients with pancreatic cancer have germline BRCA1 or BRCA2 mutations. It's slightly higher in certain patient populations, such as those of Ashkenazi Jewish descent, those with familial pancreatic cancer. But what's really important in this slide here is that 40% of patients who have a germline BRCA mutation, who are known to have a germline BRCA mutation, when you look back at their family history, they actually have no discernible family history of pancreatic, breast, or ovarian cancer. And so I really, implore the people that I speak to that we should not be using family history as a screening tool to decide who to test for the presence of a germline BRCA1, BRCA2 mutation. And actually all of the guidelines, NCCN, ASCO, ESMO, they all say the same thing, that germline testing is recommended for 100% of patients with pancreatic cancer, irrespective of family history, irrespective of stage of disease, to identify a potential hereditary cancer syndrome. The other important thing about DDR or HRR deficient cells is that we actually have new drugs that may be beneficial to that subgroup, those subgroups of patients, including the PARP inhibitors. Again, I probably don't have to go through this in detail for this group, but the idea is that PARP inhibitors will cause replication fork arrest when they latch onto an area of DNA damage, and that if the cell is not able to repair this arrested fork that leads to a double-stranded DNA break, then these HR deficient cells will ultimately die. Of course, if there is HR proficiency and normal and an intact BRCA1, BRCA2, et cetera, then the cell can recover and go on to normal cell cycle progression. But it's really this double whammy or synthetic lethality of the use of a PARP inhibitor in combination with a BRCA1 or BRCA2 or other alteration that will lead to cell death that we're trying to exploit in treating these HR deficient pancreatic cancers. And we're starting to see, we know that there are data to support this idea. The first use of PARP inhibitors for HR deficient or BRCA mutated pancreatic cancer dates back all the way to 2011. When Memorial Sloan Kettering had a small subgroup of patients that they treated with olaparib and clearly saw that some of those patients had partial responses and prolonged stable disease. There was a more systematic look at BRCA mutated cancers across the board, including breast, ovarian, prostate from the University of Pennsylvania. And 23 of those patients were pancreatic cancer patients. And there was a 22% objective response rate with a patient who had a clear, complete response. But I think what's some of the most interesting data is from the RUCA-PANC study done by Rashna Shroff during her time at MD Anderson, where they looked at patients who were BRCA1, BRCA2 mutated, and they found a 16% response rate, including a complete response. But why I like to highlight this, this trial is because they included patients with both germline and somatic BRCA mutations. And you can see from the far right there that even a somatic altered BRCA1, BRCA2 mutated pancreatic cancer can benefit from PARP inhibitor-based therapy. We do have a PARP inhibitor that's FDA approved for pancreatic cancer, which is olaparib, based on the POLO trial, which was an international randomized phase 3 trial of olaparib versus placebo as maintenance therapy in patients with known germline BRCA1 or BRCA2 mutated pancreatic cancer who had disease response or stability on platinum-based therapy. That's a mouthful, but basically it's to say using a PARP inhibitor in the maintenance therapy. And the trial achieved its primary endpoint, which was progression-free survival, which is the same endpoint that these drugs also received approval for ovarian cancer, for example. And just to show again that it's not single drug specific, this is from Kim Rice's data from maintenance rucaparib. It was not a randomized study, but her same use of rucaparib in the maintenance setting for patients with germline and somatic BRCA mutations showed a similar benefit. In fact, one of my patients was enrolled in this study and is now 5 years out on her rucaparib therapy. So one of the questions scientifically that I think is particularly important and potentially exciting is to understand what's determining sensitivity and resistance, particularly in these DDR mutated cells. One of the assessments that the POLO group undertook was to see if there was any difference in response or benefit from olaparib based on the kind of BRCA alteration that was identified. And really, they didn't find any specific difference as to whether the BRCA mutation was tested locally or whether there was a deleterious, a frame shift, or founder versus non-founder mutation in the BRCA1 or BRCA2 genes. There was really benefit to progression-free survival with olaparib across those different subgroups. We do know that, however, we do know that about a third of patients with BRCA1 or BRCA2 mutated tumors will not respond, will be innately resistant to therapy. Some of them will also respond for a while and then eventually progress. And the question is, what is causing that that acquired resistance to PARP inhibitor or platinum-based therapy? One of those potentials is these BRCA reversion mutations, which we identified in a pancreatic cancer patient several years ago, who was treated on a clinical trial with FOLFOX and a PARP inhibitor. And actually, you can see very nicely the track of her disease. This is her primary tumor in the pancreas that shrank considerably, actually almost disappeared. But then there was a small little thing starting to regrow that became more prominent by about a year and a half later. This patient was actually went on to have a Whipple, right or wrong. But the tumor sample was able to be dissected molecularly, and that new BRCA reversion alteration that was conferring resistance to a PARP inhibitor was clearly identified. And this is something that's seen in patients with pancreatic as well as breast, ovarian, and other cancers. We don't really know how often it happens in pancreatic cancer. There's been no systematic look at this. That's one of the things that we're really curious about, but it certainly can happen in pancreatic cancer where the tumor develops a BRCA reversion mutation. But one of the biggest predictors for lack of response to PARP inhibitor-based therapy is really how the patient did on platinum-based therapy. And this figure that Dr. Schroff put in her paper, I think really bears that out very nicely, where she listed out each individual patient and first said, did any of them receive prior platinum-based therapy? And if yes, did their tumor actually grow while on platinum-based therapy? In other words, were they platinum refractory? And the strongest predictor for a lack of response to PARP inhibitor-based therapy is platinum refractory disease in pancreatic cancer. So I do not offer, for example, PARP inhibitor-based therapy for patients with platinum refractory pancreatic cancer if they happen to have been found to have a BRCA1 or BRCA2 mutation. And it's perhaps because of these mechanisms of resistance, whether it's the reversion mutations or others, that perhaps this is part of why the PARP inhibitors did not actually reveal an overall survival difference. One could also argue, justifiably, that this trial was completely underpowered to look for an overall survival difference, but it could have been because of the development of resistance to PARP inhibitors because of these various resistance mechanisms. Just wanted one quick slide to show that there are other DDR targets beyond BRCA1 and BRCA2 that are being explored, as well as other DDR inhibitors beyond PARP inhibitors that are also being explored, including a lot of interest in ATM and ATR inhibitors to try and prevent the sensing of these double-stranded breaks, check and WEE1 inhibitors trying to prevent the ability of the cell cycle to arrest so that DNA repair cannot occur, and then blocking the non-homologous end joining pathway through the DNA PK inhibitors. And some of these trials are actively ongoing, including for patients with pancreatic cancer, with very promising results. So stay tuned for those results. To try and understand more broadly how patients are responding and why they are resistant both innately and in an acquired way, we actually are part of a UO1 funded effort led by Oregon OHSU, Oregon Health and Science University, to try and collect pancreatic cancer samples that we can then grow as organoids as well as conditionally reprogrammed cells, and try and assess every patient's responsiveness through extensive DNA and RNA testing, as well as couple this with ex vivo assessment of response to various therapies. And this is just an image of how we're going about doing this to try and take the samples, grow them both in cell lines as well as in organoid models, and try and explore different mechanisms of resistance. And so this is a grant that we've been trying to get funded for a number of years over and over again, but eventually we will, to be able to explore this avenue. And in fact, one of the things we recently initiated has not gotten off the ground yet. It's still waiting to officially be launched, is a national cooperative, an academic cooperative that will allow for the development of a repository of samples that are resistant to different targeted therapies, and then allow partners, research partners, pharma partners, whomever is interested, to try and explore those mechanisms of resistance with the hopes of being able to overcome resistance to the different targeted therapies. A couple last slides about these targeted therapies and DDR deficient cells. One of which is that there's been a lot of research interested in looking at whether DDR deficient cells are more immunogenic. I think that the jury is really out in this regards. There's been definitely conflicting data, but scientifically, there's a good reason to think that this may work in BRCA1 and BRCA2 mutated cancers, where BRCA1 and BRCA mutated cancers that are HR deficient, the DNA damage that occurs can get repaired, but it can get repaired through this non-homologous end joining pathway that can lead to specific kinds of mutations that are unique to the presence of an HR deficient cell. And because of that, there may be the potential for a higher neoantigen load, more tumor infiltrating lymphocytes, and ultimately a greater responsiveness to immunotherapy. And so we're trying to answer that question more definitively in a national cooperative group study led by Vincent Chung through the SWOG, and then also myself through the Alliance, where patients with germline BRCA1 and BRCA2 mutated cancers who have stability or response to platinum-based therapy, very much like the POLO subgroup of patients, are then randomized to receive either what is now standard of care olaparib or olaparib plus pembrolizumab on the hopes that the anti-PD-1 antibody will further enhance the response to therapy. We're about a third of the way accrued through this trial, so stay tuned also for these results. And then a few quick slides about the emerging targets, because I think that we are starting to see more slices of the pie for pancreatic cancer developed, such as MDM2 amplified pancreatic cancers. MDM2 is amplified in about 1% of all pancreatic cancers. As you all know, it's a negative regulator of P53, and overexpression can inactivate P53. And so these MDM2 inhibitors require an intact wild-type P53 to actually work. And there are several MDM2 inhibitors in clinical trials that are actually showing some preliminary promise in pancreatic cancers, bile duct cancers, and I use the example here on the right of a presentation last year at ASCO of dedifferentiated liposarcomas, which are notoriously also very difficult to treat. But were frank responses in these MDM2 amplified dedifferentiated liposarcomas to a MDM2 inhibitor. Claudin 18.2 is a target there's been a lot of interest in lately. There was a very important study presented at ASCO GI in January in gastric cancer. And actually, I'm surprised that we're sitting here in May and this drug has not yet been approved. But zolbetuximab was tested in combination with FOLFOX as first-line treatment for gastric and gastroesophageal patients that are Claudin 18.2 expressing. And the trial was unequivocally positive. It was a 3-month improvement in median overall survival, and we anticipate will lead to approval of this drug. But what's important about this in the pancreatic cancer context is that there's actually 7 or 8 drugs out there targeting Claudin 18.2, and Claudin 18.2 high levels of expression occur in as many as 30% of pancreatic cancers. And there are multiple clinical trials ongoing with both naked antibodies, antibody drug conjugates, bispecific antibodies, as well as even a CAR T-cell strategy targeting Claudin 18.2 in pancreatic cancer. And then finally, probably the earliest kid on the block in many ways is the pancreatic cancers that have MTAP deletions. So MTAP, the loss of the MTAP enzyme will lead to the accumulation of MTA as well as decreased adenine. These are essentially critical building blocks in the metabolism of a cell. And when MTAP is deleted, inhibition of the neighboring enzymes of MAT2A or PRMT5 can lead to synthetic lethality in the presence of the MTAP gene deletion. And there are now active PRMT5 and MAT2A inhibitors in clinical trials that are being tested in pancreatic cancers and other cancer types. So that would be another target to keep an eye out for. So you see that there are all these different subgroups of pancreatic cancer that are dissecting themselves out. And so it's really imperative that we actually test pancreatic cancers. And this is something that I'm on my soapbox about regularly, that we really need to identify these patients. There's nothing at all clinically or in terms of family history or anything about, for example, a patient with an NTRK fusion positive pancreatic cancer. You cannot identify those patients unless you go through the process of testing their tumor. And so the current guidelines do highly recommend that all patients with advanced pancreatic cancer who are candidates for therapy be tested for these actionable, uncommon, but actionable mutations. So go to close with my patient scenario that I mentioned. This patient was treated with a modified FOLFIRINOX, tolerated it very poorly. She was able to get through 4 months or 8 cycles, but during the process of that time was identified to have a BRCA2 mutation, and those results returned during the cycle 2 of FOLFIRINOX. And she was the one that was able to enroll in Kim Rice's rucaparib study. And like I said, she's been more than 5 years now on maintenance rucaparib with a somatic BRCA2 mutation. So one of the questions is when to incorporate the biomarker testing. And I won't go through it for sake of time, but it's been very difficult to do biomarker testing upfront for newly diagnosed pancreatic cancer patients because they're often very symptomatic. So I will start them on chemotherapy, but then concurrently initiate their testing, both germline and somatic. And the hope is to be able to either optimize maintenance therapy, such as using olaparib or different combinations if they're BRCA1 or BRCA2 mutated, to improve second-line therapy, or to hope that they're going to be in this 5 to 10% of biomarker-specific subgroups that have prolonged benefit from very targeted therapy. And we do have some data retrospectively that using this approach of testing patients, getting them access to the appropriately matched therapy can actually improve survival. In the Know Your Tumor program, once we crossed 1,000 pancreatic cancer patients, that was our goal. Once we crossed that threshold, we went back and looked at the patients who had outcomes information, and we separated them into 3 groups: those who had an actionable alteration and received appropriately matched therapy, those who had an actionable alteration but were not able to get access to an appropriately matched therapy, or those who had no biomarker at all, which is the largest subgroup, we acknowledge. But those who got matched therapy lived a full year longer with advanced disease than those who did not have any biomarker identified, or who had a biomarker but were not able to get appropriately matched therapy. So how do we make a difference? Hopefully I've convinced you enough that the actual mutations do exist in pancreatic cancer, and that 100% of patients should be germline tested, and probably all of them should also have somatic testing. But the question is, why is this not happening? There's very little systematic data out there, but at best, based on a publication from UCSF, at best, probably about 30 to 45% of patients with pancreatic cancer are getting germline testing, and perhaps as low as 10 to 15% are getting somatic tumor testing. Now, this is also going along with the idea that many of these pancreatic cancer patients, there's a lot of cynicism out there, and so many of them are not getting treatment at all. In fact, we put out a paper that showed that more than half of patients with pancreatic cancer, 45% of patients with pancreatic cancer do not receive any treatment at all from the time that they are getting diagnosed. None, nothing, not surgery, not chemo, not anything. I think that we really should be changing our algorithm altogether, where at the point of diagnosis, just like in breast cancer, where at the point of diagnosis, there's ER/PR HER2 testing that is done, that these specimens that are labeled likely pancreatic cancer should also be undergoing NGS and RNA fusion testing. There should not be a conversation back and forth between the physician and the pathologist. The pathologist should be able to just be empowered to send that test right away. In addition, we should be sending patients for universal germline testing, and systems really should be put in place to capture the blood and saliva testing that's needed for germline testing at the time of the initial visit. And that's based on the fact that we do have data to suggest that cascade testing will ultimately save lives by preventing breast cancers, ovarian cancers, and hopefully catching other pancreatic cancers very early. So with that, I'd be happy to take any questions. These are just the group of people that I've worked with over the last 10 years, some amazing people across the country and across the world. And I'll take any questions.
Thank you so much, Dr. Pishvaian. Such an incredible presentation and really significant results showing the improvement in survival with integrating sequencing. It's really great. I'm going to start off with just a quick question before I open the floor to everyone. So you mentioned all the data, all the sequencing's been done, all the testing's been done in the studies. Are they all whole exome sequencing, or did you initially start off with like targeted panels?
No, they're not whole. Most of them are not whole exome sequencing. Most of them are a relatively targeted panel, somewhere between 200 and 600 genes, depending upon the testing lab that's being done, either the academic testing lab or the retail testing lab. For one of the slides that I had, one of the papers did do whole exome sequencing on all of the patients. It didn't actually really increase the rate of actionability to any great degree.
Okay, thank you. All right, Tony, I see that you have a question, and if anybody has a question, please just raise your hand and go ahead and ask the question.
Yeah, great, Mike. Thanks for that very sort of erudite discussion of a very, very tough disease. Now, I come from the leukemia world, so I think we have higher expectations of drug response than you probably do in the pancreatic cancer world. So when I look at that, I see like, of course, there are the occasional examples of patients who have fantastic benefit from these single agents that they're getting. But like certainly a lesson that we learned decades ago in the leukemia world, and in fact, it's been demonstrated FOLFIRINOX, is that combination therapies are generally tolerable combination therapies outperform single therapies. You get less drug resistance. So how do you see going from where you are now, identifying these individual single agents with, yeah, I know some people benefit, but sometimes the curves aren't that separated and the patients almost all die eventually with marginally different kinetics. How do you see going from those targeted single agents to personalized combinations?
Yeah, I think that's a great question, and it is helping us to understand that we definitely can't bucket all of these targets and all of these drugs into one bucket. They really have to be individualized. So, for example, there are single target, single drug sort of paradigms that really can be very significant, like the NTRK fusion targeted tumors treated with TRK inhibitors. The response rate in those tumors is 80 to 90% with the responses that can be very durable. None of this we know is going to be curative, but in terms of prolonging survival, it can be very, very meaningful for a pancreatic cancer patient with survival times that are prolonged by, like I said before, years. Those examples, unfortunately, are less common and often will lead to a rapid FDA approval, like with entrectinib and larotrectinib. The harder question is going to be, and I think this is what you're getting to, is what about, for example, zenocutuzumab, which had a 45% response rate in pancreatic cancer? That's not quite enough to go to the FDA and say, we need to have this approved. It's also not quite enough. The duration of response is not all that long, but it really does open the door to say, okay, this is a receptor tyrosine kinase that's being blocked. There must be the opportunity to combine other therapies as well, either targeted to that specific pathway or just combining with other chemotherapies, the way that we targeted an anti-EGFR therapy with chemotherapy in colorectal cancer. So I think that the more these targets can be identified, the more experience that develops with these individual drugs, and we start to get a sense of how much they really do perform, then we can start to investigate other clinical trial combinations with targeted therapies plus either other targeted therapies or chemotherapies.
Okay, and I have to ask, you're speaking to the Society of Functional Precision Medicine. So where do you see, like, personally incorporating sort of functional ex vivo studies into this choosing of additional drugs?
I think that there is a tremendous potential for trying to understand how these tumors are going to respond. So we have a trial ongoing right now, led by the University of Toronto, Jennifer Knox at the University of Toronto. It's called the PAS-01 study. It's a Stand Up to Cancer funded study where patients are being enrolled, getting a biopsy. It's being sent to Toronto, where they're doing extensive molecular testing, including growing the cancer cells as organoids. And then we have our cancer molecular grand rounds once a month, where they are doing extensive ex vivo testing of these organoids, with testing multiple different therapeutic single agents and combinations, with the intention of recommending second-line therapy for the patients. And that's, I think, where the most value where that has the most potential value for taking a sample of a patient, testing it ex vivo, coupled with extensive genetic and RNA testing, and then deciding what next to do for that patient. It's very, very hard, and I'm sure many of you experienced this across disease types, to wait for that functional testing for the first line therapy for the patient, but to be able to do the functional testing while you start standard first line therapy and be ready for second line therapy. That's where I think the greatest potential is.
Great. Well, please let Dr. Knox and her colleagues up at Toronto know that we would love for her to get in touch with the SFPM and let us know what she's doing.
Yeah, and there's groups of you here that know that we've been trying to do this in the context of clinical trial as well, with some of the retail companies that are out there in development. So, we're all on board. It's just part of it is the difficulty of getting, to be very blunt, getting sort of our governmental funders to support these ideas.
Thanks, Mike. Do you have any data on G12D inhibitors to talk
So
about?
the G12 data, I mean, I only know anecdotally, talking to my colleagues, because I refer, we just opened our own trial, not our own, but we just became part of one of the trials here at Hopkins. But there's also trials in and around the DC area and New York and Boston. So I'm regularly referring patients because I see so many pancreatic cancer patients with KRAS mutations. I'm regularly referring them to these various clinical trials. And just purely anecdotally, the experience is very mixed. There are definitely some KRAS targeted therapies and pan-RAS targeted therapies and KRAS degraders that don't work at all, some that seem very promising. I think we just need to let these phase 1 trials bear out. I actually haven't had a chance to go through the ASCO abstracts yet, but I do plan to in the next couple of weeks. And if there's any of those KRAS targeted therapy trial data being presented, I will definitely be interested in attending. As you probably know, targeting anything but G12C is more difficult just on a pharmacologic basis. And so I think that it's not clear how effective they're going to be compared to the KRAS G12C therapies.
My favorite question is also, what's been your experience in getting off-label drugs, and how do you get those paid for?
Off-label drugs that are approved. I've actually had pretty good experience. I talked to my colleagues across the country, and there's a tremendous geographic difference that I can't explain. I know a lot of people in California have a really hard time getting off-label therapies. I usually have pretty good success at getting off-label therapies. But what I do have a lot of trouble with is this sort of right to try thing that came out in the last few years. I mean, I don't know how people are getting access to unapproved therapies other than sitting and writing individual single patient INDs, which is incredibly laborious and difficult and being done without any proofs. I mean, I could write a single patient IND for a KRAS G12D inhibitor if the company wanted to give me the drug, and with no data that it's going to benefit the patient at all. So I'm a little more wary of that approach. But off-label approved therapies, approved for other diseases, I've definitely had success with.
Thank you.
Moody, you have a question?
Yeah, hi. Hi everyone. Hi, Dr. Pishvaian. Thank you for this amazing talk and just introducing us to all the absolute latest that's happening, and what your group is doing and all of the groups here. My question was related. Well, I have two questions. One is, what are your thoughts on the evolvability of tumors? And okay, let me just introduce myself first. I'm coming from an organization called Cancer Commons. Some of you may have heard of it, some of you may have not. We work directly with cancer patients and we match them to trials, expanded access options, etc. And we get to see a different side of the picture a lot. And we actually look at all of the molecular information, whether it's somatic or germline, in context of the treatments they've received prior and just where they're headed, you know, what the scans are looking like, just to sort of point them in the correct direction maybe, and also talk to oncologists, see what their opinions are. We also have been in conjunction with PanCan holding some virtual tumor boards as well for some of the patients. But my questions, what I'm seeing from this viewpoint is that two things. So questions for you. What are your thoughts on evolvability of tumors and on the traditional sort of experience-based, very makes a lot of sense kind of approach, is that you have only so many arrows in your quiver, so you try to sequence it with standard first line first. You know, you go with the FOLFIRINOX or the strongest if you can, depending on the ECOG status. Then you go with the Gemabraxine. Anyways, you sequence that, and then you try new things. What are your thoughts on all of this?
Yeah, these are great questions, and I know your group well. Lola Rahib is a friend of mine. But so let me answer your second question first, which gets back to the idea that for not very long, thankfully, I became faculty in 2007, and FOLFIRINOX started to become regularly used probably about 2012. And for those 5 years, I hated giving gemcitabine. All I did is I watched patients steadily decline. And now we really have the opportunity to take patients and make them feel better buy them sort of a plateau of time, a window of time, so then we can do other things to them, explore their genetics, try and identify clinical trials for them. So I do not hesitate to get them started on chemotherapy up front. What I try and do is to do the testing right away so that I can move them on to the next line of therapy before they go on to the second line therapy. So if I've started them on Gem/Nab-Pac, then I have them ready to start on the targeted therapy if there's something there, or same with FOLFIRINOX. So it's not that I'm sequencing because I think the FOLFIRINOX or the Gem/Nab-Pac is better than what the targeted therapy they might have. It's just to buy me time to be able to do that testing. And I faced maybe just once or twice, I faced a scenario where you have a very unexpectedly actionable alteration in a patient that you're tempted to pull them off the therapy, the chemotherapy, but actually in both of those cases, the patients were doing really well on their chemotherapy. And so I said, okay, I'll just keep this in my back pocket until and when their cancer grows, which brings to the second point, the second question you raised, which is the evolving nature of these cancers. So surprisingly, pancreatic cancer doesn't have to, it doesn't actually seem to change all that much the way that other cancers do. There have been studies that have been looked at. We did a small study through the Know Your Tumor Project. Chris Iacobuzio did an amazing rapid autopsy study. And the long and the short of it is that these pancreatic cancers don't evolve that much genetically over time as they get exposed to different chemotherapies. Now, that's probably not true for targeted therapies. And in fact, targeted therapies, we know that tumors in general will develop resistance to. And so I think understanding resistance mechanisms will be really critical. It's just that not enough groups are doing it systematically, which is why we're trying to start that trick group to do this systematically so that scientists can have access to all of these samples to understand the mechanisms of resistance that develop.
Thank you so much. Diana, can I slip in one question? Just very related
go
to
ahead.
this. Okay, which is just what is the largest stumbling block you're currently seeing if you were to replicate nationwide what you're doing, because this is amazing. So
Testing. It is amazing how few people are getting tested. I mean, and that's true across disease types. You know, for lung cancer, where the actionable alterations can sometimes lead people to live 7, 8, 10 years, the testing rate is still only 70%. That's a heck of a lot better than the 10% for pancreatic cancer, but it's just malpractice to me to see that 30% of lung cancers are not being tested for EGFR mutations. So it's just testing.
All right, thank you. We're going to take one final question in the chat, which is from Joanne. Let's see. Your question is, what are your thoughts about mRNA vaccines like the one published in Nature?
I will claim that I'm not an expert in this at all, other than I think that the data was really promising. And I readily refer patients to clinical trials that have this. It's just so hard to get these patients on these clinical trials. So I'd love to have the community figure out how to make these clinical trials more available to these patients, because there's plenty of them that want to be treated with these therapies.
Okay, thank you. So I really want to thank you so much for an incredible presentation. We learned a lot and we appreciate your time and being here. Thank you all for being here.
Thanks so much.